Hello, everyone. Welcome to ADLM's CLS Council webinar on lab interface validations. We're just going to give it a couple more minutes here to allow people to join, and then we will kick it off. Okay, as people are joining now, I just want to remind everyone to make sure your microphones are off, cameras are off, and that if you have questions during the presentation you want us to pose to the panelists, please just enter those into your comment section in the chat, and I will be monitoring that. And if we have time at the end, we will try and bring those up to our panelists. Before we jump into the presentation on lab interface validations, I just wanted to also discuss a little bit about the CLS committee. Our charge as a CLS council guides ADLM's activities and programs to address the professional needs of ADLM's current and prospective clinical laboratory scientist members. The council lends the CLS perspective to the broad ADLM programs and oversees targeted activities to engage and involve ADLM's clinical laboratory scientist members. The CLS Council contributes to identifying topics and areas of interest and makes the program recommendations, seeks input from CLS constituencies, and provides content and advises on strategies to expand ADLM's membership. Of the things we do as a committee, here are just some great examples of us at work. So this is increasing awareness and networking. We also provide resources and educational opportunities to all the ADLM members. This is just some of the examples of the things that we have contributed. And the link there is at the bottom. Providing resources and education, really just pinpointing here that we have an ADLM annual meeting coming up, and we do have special CLS day rates. Please use that QR code at the bottom there to find out some more information regarding that. So Tuesday, July 29th is the next ADLM 2025 meeting that is in Chicago. So if you have any specific questions about the CLS Council, please reach out to our current CS Council Chair, or Jordan Bradford, who's on the call today too, who's our CLS Council Liaison. Without further ado, I'm going to introduce our panelists today. Let's stop sharing here. With us, we have Christopher Kenyon. He is a MLS who is currently serving as the coordinator and technical specialist for the Avera McKenna Special Chemistry Department. Since joining Avera in 2012, Chris has played a pivotal role in driving technology advancements across the laboratory. With a strong technical background, he has successfully led the integration of automation within the core lab, leveraging middleware to streamline processes. Chris has consolidated various manual platforms into efficient, automated interfaces, spearheaded numerous LIS validations across multiple software versions, and introduced the use of digital maintenance logs, among other impactful transitions. His expertise continues to enhance the department's operational efficiency and technological compatibilities. Next, we have Lois Lames. She is currently serving as the Manager of Quality and Regulatory and Safety at UC San Diego Health. Lois hails from New England, the second of 6 children. She graduated from Providence College, a small Catholic college in Providence, Rhode Island, and moved to California to pursue a career in laboratory medicine. After obtaining her clinical laboratory science license, required in California, she worked at Scripps Memorial Hospital in La Jolla, where she ran the first laboratory outreach program for them, setting up 2 satellite laboratories and establishing a successful laboratory program for over 50 skilled nursing facilities in San Diego County. She has worked at Laboratory Corporation of America in molecular biology and then quality assurance for their Western region office. She is currently serving as the quality assurance manager, overseeing 6 clinical laboratories at UC San Diego Health. She's a member of the ADLM, CLM, and ASQ, for whom she achieved the ranking of a certified manager of quality and organizational excellence. Lois is also a green belt in Lean Six Sigma and black belt in Kung Fu. And finally, we have Dr. Obstfeld, as the Associate Chair of Pathology Informatics, as well as the Associate Medical Director of the Coagulation Laboratory at Children's Hospital of Philadelphia. After receiving his MD and PhD degrees from the College of Physicians and Surgeons at Columbia University, he went on to train in the clinical pathology at the Hospital of the University of Pennsylvania. At CHOP, he learned laboratory informatics initiatives within the pathology department and across the health system. So welcome to our panelists. I will also introduce Leslie Cooper, who will be moderating the presentation. Thank you for joining us.
All right, again, yes, thank you, Michelle. We want to thank everybody for joining us today. We'll get started with our panel here. We've got 3 really experienced experts here to help us with our laboratory IT validations. Today we're going to kind of focus more on initial validation, so new testing, but feel free to ask whatever questions you have up in the chat located on the right. So we'll get started. Lois, can you explain how long you have seen validations take when you're bringing up a new test on instrumentation?
Yes, thank you, Leslie, and welcome everybody. So to answer that question properly, we need to know something about the test. So as you know, in the laboratory, we have single tests, we have panel of tests, and we have tests with comments, we have tests in that are very wordy, as well as numerical and qualitative, quantitative. So the length of time a test takes to validate would depend on some of these. If it's a single test and it's quantitative or even qualitative, then it would probably take, we've done it in a day, on certain small tests. And if it's longer or more complicated, then it could take upwards of a week to 2 weeks. We've had one panel go as long as a month, but that was because we were having some problems interfacing with our HIS from our LIS. So those are some things to take into consideration.
Excellent. So next question, Dr. Obstfeld, we'll let the other panelists weigh in on this one too, because this one's a pretty important topic, but can you explain how you organize and prep for your validation plan, and what do you all include in your validation?
Yeah, this is a really key question. In our validation plan, obviously we start with a pre-written up validation document that gets circulated, and we ensure that directors, managers, anyone else who can weigh in can ensure that it's comprehensive. In that context, we're really dividing it broadly into 3 types of interface testing. That starts with connectivity testing, which is more of an IT thing, but also very important. Obviously, you need to make sure that in this case, we're talking about instrument can talk to the middleware can talk to the LIS, that all the IT components are in place. We have map record testing, which is the process of ensuring that the records essentially are hitting each other correctly. So the hemoglobin on one side is hitting the hemoglobin record on the other side. And then we have scenario testing, which is more of the comprehensive type of test in which we're challenging that interface to ensure that it can handle sort of the typical clinical scenarios that we expect to be running. So in that context, it's not so much an issue of having lots and lots of scenarios, but really thinking through what are the challenging scenarios that we expect to see in this testing workflow. So are there comments? Are there wordy comments that they're going to see? What kind of flags are there going to be? What are the reference ranges, and do they depend on some demographic factors like gender and age? How does the instrument handle errors? So there's going to be errors. There are going to be situations where things don't line up correctly. We want to see what those errors look like so that we can monitor that correctly. And some of these validations actually involve running samples. Some instruments are not able to do sort of a virtual type of testing. You have to actually run samples. So you also have to make sure that you have that in hand. You have, if there's cartridges involved, you have the cartridges that you need, which can take quite a while, especially if this is a non-built situation and you have to get those from the vendor. And then finally, just making sure that you have the team. So the team is not just your own lab personnel, it's also the lab information system support team. It could involve a special interface team. It could involve the EMR or HIS team as well. So making sure that they're also kind of involved and in the loop as to what their requirements as part of this plan is going to be.
Excellent. Lois or Chris, do you have any information you'd like to make sure you include in your validation plans?
Yeah. Oh, go ahead, Lois.
Oh, no, Christopher, I've already spoken. Go ahead.
Oh,
I'll go
yeah,
after you.
absolutely. Yeah, I would say more from a technical side of things. Again, I would agree with Dr. Opsfeld. Having a checklist to identify major components of a validation, I think is absolutely paramount. Now here at McKinnon, we absolutely have one of these, and I would love to list everything in this list, but it might be a little bit exhaustive. Suffice to say, again, from a technical standpoint, some of the items that we would want to include are things like writing the validation plan for technical considerations. So, for our assay, the accuracy, linearity, precision, all of those items. Submitting the LIS work order. Same thing on the front end of this, the automation and middleware considerations. And when I say that, I'm talking about like how are pre-analytic teams handling these, how are staff handling these. So again, writing SOPs and staff training would also be major considerations from a technical end. And suffice to say, I would say, no two validations are going to be exactly the same, but I cannot emphasize this enough. Just having some sort of overarching organizational plan would be very, very important, because it ensures time and time again that although, not all items are going to be utilized, they will at least be considered and specifically not forgotten. That in my mind is really, I guess, what would be primarily important.
Oh, I totally agree with both you and Dr. Ostfeld. So coming from QA, we document everything. So, if you didn't document it, you didn't do it. So our first thing is the plan, which goes after sorry about that, which goes over what Dr. Ostfeld was saying, get your team together, discuss everything that needs to be done, and put that in the plan. Then that is signed by the director or designee. That's the guideline that we go by. But we also have what Christopher mentioned, a checklist, sorry about that, a checklist that the supervisor of the lab section that is implementing the test is now responsible for making sure everything is done. So even though this isn't a full-blown new LIS system that we're doing, we still follow the IQ, OQ, PQ format so that we make sure that the test is, I am so sorry, that the test is built, that the it's end to end is done so that the provider gets the actual result that we intended them to get, including all the flags and any comments that go along with that. So yes, exactly right.
Those are all very good points. Thank you. So now that we have our validation, we're working on our validation. The next thing is, how do we organize the data that comes from the validation? Chris, would you like to start us out and explain kind of how you organize your data after you're done with your validation?
I'll be honest, I'm probably more of an old school approach on this, which is to say I'm more pen and paper based. I like screenshot printouts, instrument printouts, internal inquiry printouts. Again, I like to put all those in, organized labeled binders and store for reference. And to be honest, I know that everybody is going to organize things a little bit differently with how they keep these records, but, kind of to build off of what Lois was saying, just a moment ago, I mean, really, the whatever process you use, I don't know that it matters so much as as long as you're getting the adequate completeness and, the documentation is going to be there for reference when like an inspection occurs. That to me those are kind of the key points to really expand on. And to build off of that completeness a little bit more, I know Dr. Obstfeld was saying this earlier. When I'm referring to completeness, what I'm saying is, let's say you're validating, reference ranges on a new assay. Well, are they different for adults versus children? Are they, sex specific? Whatever that process that you have for organizing those documents, it will need to adequately encompass all of the testing variables for that component. And your documentation, whatever that may be, really should show that.
Agree with Christopher. I would also caution. I know in this day and age, it's we'd like to go paperless, but I found on one of our self-inspections, thank goodness, not a real on-site one, where the um, documentation was electronic, but it was only on one of our LIS people's computers. So that person was not in that day and we had no access. So if you're going to have these things electronically, put them on a shared drive or Teams situation where anybody can get a hold of it during an inspection period. But I'm with Christopher, hard copies, I love hard copies.
I'll come in with the contrasting approach, not a view. I think that hard copies are definitely the way to go. We have standardized Excels and a file structure in our shared drive where we store this information. These standardized Excel, they're templated. They run through the entire scenario so that we ensure that in every scenario, every time that we do this, whether it's an upgrade or change to an interface or a new interface, we're making sure to hit each one of these items that we're looking for. We also store our screenshots in there as well. And I think that a paramount importance is just the organization of it. It's just making sure that if an inspector comes or if and when the inspector comes, it's very easy for you to retrieve, the specific component that they might have a question about, or if they're just interested in the last upgrade that you did, that they're able to go, okay, right through the lab sections, right through the different components and find what they need.
All right, so the next question, Lois, is if you have multiple instruments that are the same, do you have to validate all of them during the validation?
You know, I thought about this a lot, and the bottom line is yes. Um, the the validation of the um, software is done, it can be done on one analyzer. But if you have redundant analyzers, you want to make sure that they will all function the same way and give you the same answer. They should, but you don't want to assume. We've had situations where once you go into production, something glitches on one of the lines that you have, if you have multiple lines, like a Roche analyzer or Sysmex analyzer. So it's important that you do validate the redundant analyzers. And it's up to your lab director how detailed you want to go with the validation, you know, full-blown verification type situation. And that's the decision made by your laboratory director. And when I say laboratory director, I'm talking about the CLIA director or the designee as approached, as designated by the CLIA director.
I think it's worth pointing out here that there's a LabGen checklist item around ensuring that there's traceability to the specific instrument that producers. It's a phase one, but nevertheless, even phase ones count. So by definition, no two instruments are going to be exactly identical. You're going to want to make sure that you have that data and it's accurate. And just to, I agree with everything that Lois said. Just to offer up another piece of data to think about here is whether you're dealing with a middleware system in which both instruments are going to the same middleware and there's one interface from that middleware out. So again, that's sort of a lab director slash designee slash IT person kind of decision. You have to really think through, okay, is this the same exact interface once it reaches the interface engine of the hospital at that point?
And real quick, just to build on this a little bit, this is something that when we're talking about like walking through all the instruments, this was something when I first started doing LIS validations, I didn't really get to see what that was like from the programming side of things. And so when I would first do a lot of these workups, I would actually set meetings with my LIS team members so that I could go to them and physically kind of see how this occurs. I found that was extremely important because, and just to kind of build this off with a little story. I had the team member who was working on two instrument builds in our LIS. These instruments were feeding information into the LIS, and they had one instrument working. They said, "Okay, all I have to do is copy paste this, and into the second instrument, we should be good to go." And they use that term copy paste, and so you assume, oh, this is going to be exactly the same. It should be a pretty quick process. But what they actually did was they brought up the screen with the settings for the first instrument, and then they brought up the screen with the settings for the second instrument, and then they were hand typing every single one of these settings into that other instrument. So again, without actually physically doing that validation, without actually ensuring that I've gone through and tested all of those out, how can I say that, you know, everything was copied perfectly? I mean, the reality is I can't. So, absolutely, yes, absolutely. Go through and validate all of your instruments.
That's great information. All right, next question we'll direct to Dr. Obstfeld to start with. We know that some instrumentation requires middleware, and so some of our validations require middleware. Can you describe how you have validated laboratory interfaces that involve middleware, and how do you work with IT and vendors to ensure the rules are firing appropriately?
Yeah, so middleware does make things a little bit more complicated. Oftentimes, middleware can be simply a pass-through piece of software where it's just handing the data from the instrument over to the lab information system, or the middleware might actually be changing the data or operating on the data in the form of auto verification rules or reflex testing or different forms of rules like that, applying reference ranges. In this situation, it becomes even more important that you're really checking all the different pieces of software involved in that chain of custody, if you will, of the laboratory data. With middleware, sometimes it can be challenging because oftentimes we really do require the vendor to be involved. And as a result, that can extend your timelines. It can create misunderstandings and miscommunication. So you're really going to want to have some level setting meetings with everyone who needs to be involved in terms of the expected responsibilities of everyone. Yeah, I mean, these sorts of issues around reflexes and rules become extremely important because, as we all know, this is part of the CAP checklist and is really the focus to a large extent of the checklist with regards to informatics. So to the degree that you need that vendor to provide you with a printout of all the rules so that you can check them manually, so that you can ensure that you have scenarios that hit each of the rules, it just sort of brings all these points even stronger to the fore.
So agree, Dr. Osfeld. And the vendor, like you said, is very important. We had a situation with glucometers when we changed to a new glucometer. And the vendor was supposed to help with the communication through our interface to the HIS so that the nurses could do their insulin calculations and all that sort of stuff. Once we went live, it didn't work. And so we had to have luckily the vendor was on site. We made sure the vendor was on site on our go live day. And we ran around the hospital, all 8 floors, making sure everybody was properly interfaced, and then did that. So that was a situation, but most everything else goes smoothly.
And not to say that working closely with the vendor is a bad thing by any means, but our organization, I think we've just found that in dealing with middleware or in dealing with a lot of the problems that we would come across, for us it just became easier to have somebody actually on staff who was kind of our middleware liaison. They were trained with the programming, and so they can help us build our validations. They also work as correspondents between our organization and the vendor for more technical, when more technical issues arise. Similar to like an LIS member, usually it's this person that we would say this is our go-to for our to help us complete our projects. And we've just found that that's been extremely helpful when working through a lot of the issues with our middleware.
Excellent.
All right. Next question, Chris, we'll start with you. What do you wish you had known before your first validation? And what advice would you give now to people starting a validation here in the future?
Going back to some of our previous answers, having some sort of like overarching organizational plan is just absolutely critical. It really does help you set timelines. You can assign goals to, different people. You can even customize that so that it can occur in efficient order. And all of these things, having that organization plan ensures that you don't miss something. Because the other thing that, when you're doing these types of validations that you absolutely hate to have is you get through everything and you're like, oh shoot, did we update the activity menu on our, oh no, okay, you know what, we got to go back and we got to make sure we get this done, etc. And you have to spend extra time doing those things. Having an organizational plan allows, that you're assigning these out, you're setting these goals, and you're not missing anything. So again, I absolutely emphasize this. You really need that organizational plan. Absolutely critical. That would be the first thing. The other thing I would say, is just good to have are strong lines of communication to, all the parties that are going to be involved, whether it's your LIS team members or other sites. Um, like as an example, when we first got our automation line, I'm trying to work through some of the problems and I'm trying to set things up in our LIS, have them, program and build out certain things. And I'm realizing that what is working for our core laboratory, might not work so well for some of our smaller clinic sites. And I should preface this by saying that, as a side project to getting our automation line, one of the other items was, standardization with our instrumentations across all of our sites. And so I'm on the phone and I'm literally setting up meetings with, these other, the site coordinators and, we're discussing these changes, but the information is, very impromptu. The meetings are very impromptu. The information is very slow to disseminate to the smaller clinic sites. But fast forward to today, and that's evolved into our core lab subcommittee, where a lot of these processes are very streamlined. We've worked through, communication chains and all of those. So I would strongly emphasize, having, whatever process you need to have, even if it doesn't exist, build it. Um, you know, just make sure that you have a strong way to, communicate information. Like I said, whether it's to other sites, whether it's to again your QA team, your LIS team, whatever it be, just make sure that that chain is there.
I'll pipe in. Oh, sorry, Lois. Right out of you there. Sorry.
Go ahead.
Um, so the one thing that I'll add here is don't forget about post go live, right? Because this is really that's the only real testing that you're gonna have when you're really in production. In one of my first validations, it might have been my first one when we were going live with the new lab system. Shortly after go live, I was in a room full of clinicians and we were reviewing charts and I started noticing some weird flags related to our results. And I thought, wow, this is a new feature, I guess, that came with the new lab system. Looks like a nice flag. Um, After a couple of weeks, I hovered over one of them and it said it was an other flag. And I was like, this is a little bit funny. Turns out that one of the new flags that was being sent over from the lab system was not being recognized by the EMR, and it was replacing it with just like an other miscellaneous type flag. I think it might have been like a low value or up arrow, down arrow, something like that. And so you really have to continue and just check these things after you went live as well. Don't just let it sort of don't take it for granted that the testing sort of found everything. This is your real opportunity to look at all the scenarios when you have actual patients that are there as well.
Mhm. And one other thing that we've learned too is billing. So we have built some tests, or actually one that we were going about 6 months when we realized it wasn't billing. We weren't getting anything for it. So that's part of our checklist now, is the make sure that our rev cycle is involved and that they know what the test is and it's that part of interface, to say, use the better term, is built for them to be able to build.
I'll just add one more point since we have a little time, I guess.
Yeah,
I don't know if anyone here has any struggles with getting everyone they need around the table, but they absolutely shouldn't. And this is a regulatory requirement. This is something that we're required to do by federal law, and that there's nothing that moves people in healthcare more than complying with regulation. That and maybe billing. So, if you're having struggles, just, make sure you brush up on, your CAP checklist items, your CLIA requirements. There's also a CLSI document of best practices that you might want to check out as well. So hopefully that helps you get through any bottlenecks, if there are any. Hopefully not.
It's a very, very good point. Doesn't look like we have any questions from the group yet, but I have a couple of additional questions from some others that we had gotten before this that I can kind of pose to you. And again, if anybody has any questions, please put them in the comment section. We'd love to have these guys answer them for you. Could you maybe walk us through some extra resources you found you needed, but were kind of unexpected, like things you didn't anticipate needed, and then as you got into it, you found out they might be helpful?
Sources. Well, we've already talked about billing, getting your rev cycle involved, having your vendor. I think the planning, once you're doing your plan, like Christopher and Dr. Osfeld said, is really significant to make sure you've got all your bases covered. And think I don't know if anyone's ever done an FMEA, but those are really not a bad process to use to try to do that. So nothing falls through the gaps.
I would say for things that I've found for extra resources, I found that there are certain things, and again, these aren't really a requirement, but from what I would say, from just experience, I've learned is that if you can come up with things like, to use the term Dr. Emmer said, when you're bringing everybody to the table, things that help everyone there kind of understand what's going on with the process. Anything that you can do to make that a little easier, I have found, like I said, just through experience, is very, very helpful. So as a case in point, like when I've worked on some more complex calculations, ones that might use, multiple assay inputs, things that are going to be applied across, multiple panels, utilizing additional variables, things like that. I've learned to, through experience, not just to, slap that equation down on a piece of paper and just tell my LIS team, make it work, and that's not to say anything about that. I mean, these people, I'm convinced these people could make a car fly if I gave them enough time. But I mean, the reality is what I've learned to do instead is, like work up the equation in Excel, break it down component by component with cross references to other calculators and clinical references. And in this way, the LIS team members can actually piece apart the calculation so they can see what each component should come out to. This simplifies that programming process. And as I've been told by some of my LAS team members, this is very helpful as the equation program. Oh, yeah, fun fact, does not always typically follow like PEMDAS order of operations. So having things like that definitely, again, not a requirement, but is something that I've just found is very helpful. Then additionally, other things, maybe a little bit more traditional organizational things like flow charts, so that they can see how certain algorithms are supposed to function. All of these things, anything you can do, like I said, to make that easier, it helps.
And we've used Gantt charts too to keep everybody on board and communication open and routine meetings as we go along.
One resource that we haven't really touched on that I've used a little bit lately is data analytics, meaning our data analytics team. So that kind of gets to looking at the data and how it looked before the validation to after the validation. Are there any funny things that are coming out of the data? A lot of times, the data kind of encompasses a lot of weirdness and workarounds that people do, and it all kind of shakes out in the data. If you start seeing that all of a sudden, you go from, let's say, 10% of your samples are abnormal to 50% abnormals, there's something going on, you have to kind of investigate it. And the sort of data warehouse is the very, very end of the data journey. If you say it's starting from the analyzer, it goes to the LIS, the EMR, and then finally that data warehouse. So take a look at what it looks like there. If there's a problem, you might find it there.
We've also done training too for the staff on if it's a new interface, like when we changed over from Sysmex from one of their old interfaces to, I forget what their ClearSphere or something. Thank you. Yeah, we changed that, and there was a different way of answering some certain situations. So we wanted to make sure that was everyone was aware of those.
Very good. Well, looks like we got a couple of questions in the chat. So we'll start with one, and the three of you feel free to answer as you see fit. Are there any good sites that would help us complete a plan and validation list? As one who's never had a new system, we don't know what we don't know or need. I fear not having enough validation data due to people wanting to get it done. So do you guys have any good sites or resources that the listeners can use to help make these checklists?
Well, Dr. Armsfeld made a suggestion to use CLSI documents. They have a very nice validation process all laid out on what to do. They even have, I think at the back, I think they even have some forms that you might be able to use. Other than that, you can Google the process too. Just, make sure that it's complete IQ, OQ, PQ sort of process too, that you're not leaving something out inadvertently.
I mean, I think we all kind of do this, but talking to your peers, unfortunately, there isn't a lot published on this, it seems. There's a CLSI document, but I think like most of us, when I go to inspect another place, I kind of take a look at how they're doing things, and oftentimes I'm impressed and find something that I'd like to adopt myself, which we know the CAP inspection process is supposed to be this sort of collaborative process.
It's very true. We have picked up some best practices and brought them back. Yeah.
And then, just to build on the collaborating with your peers. I mean, I think if I'm being honest, I think our checklist originally actually started as kind of an evolution of a list. And I'm talking about, like an actual checklist, like as in the person that made this for us literally had a clipboard, and, they would just write down everything that they were doing for a validation. This was our new test development coordinator. She's since retired. But she would go through and she would write down everything she was doing for the validation, everything that she, had to consider, problems that she ran into. So she'd say, oh, well, I need to make sure I include this. And then for the next validation, she'd go through and write down everything she was doing for that one. And eventually that list evolved into a much more comprehensive one. QA got involved and had, a lot more feedback for, okay, let's make sure we make this, certain items, from a, like an accreditation standpoint, like more of a, make sure we're hitting on the foundational topics and things like that. And eventually it got to the point where, again, every coordinator is giving their input as to, oh, hey, when I was doing this validation, I found, this was helpful. So we added that to the checklist and so on and so forth. So, it's funny because, it's one of those sayings, it's like it takes a village. But, it was really everyone's experience, that we combined to make a lot of these checklists. So, I would say if you're struggling, if you're really stuck on something, don't just try to tough it out by yourself. Ask for help.
Those are really good points. Maybe kind of tagging on to the comment about checking with your peers. If you are part of ADLM, we do have a CLS forum. So you can actually type questions and get feedback from other people within the industry. So, sometimes finding those forums or other listservs can be a really helpful resource as well.
Hmm.
Have another question. It says, I was wondering if you could go further into the traceability requirement. If you were going to a new instrument of the same current instrument, what do you do for traceability for your records? Do you differentiate it in your LIS or keep records of the date change? For example, using an AU 480 and replacing it with a new AU 480.
So we're not just talking about traceability of who performed the test, or are we talking about traceability for before the implementation? What are the rest of you think?
Yeah, I think the way that I'm reading it is, you know how we talked about if you're like what traceability back to the originating instrument.
Mhm.
So some systems might just list like it's an AU 480. So if you get a new AU 480, you're going to see that same instrument in the LS. So how do you trace it back to if it was the old one or the new one?
We would differentiate between those in our system. Um, if we have two of the same instrument, we differentiate between them. If we get a new version, I think that's an important piece.
If we're using a new interface and it's the same test, same instrument, we actually build another test. So then that's a brand new test and it's then traceable as a new interface, and the instrument number, say we have redundant instruments, we'll have Sysmex 1, Sysmex 2, or that sort of thing, already built in there. So that's how we would trace the difference between the old interface and the new interface.
And to build off of that, that's essentially what we would aim to do here as well. I believe new instruments, even though they are even if they are the same, make and model, if it's a new instrument, it's still going to be identified in our methodology. From our LIS standpoint, it's going to be labeled as something different. So for instance, like right now, if we have, two DXIs, one is a DXI1 and DXI2. But if we got a brand new AU instrument, then we would have to identify that differently, than the one that we're currently using as well. So we treat it kind of like having a second instrument. You want to have some way to identify that it's something different.
Okay, I think we have time for one more question. Let me see here. Can you explain the levels of validation required? For example, are there differences between the instrument to middleware, to the LIS, to the EMR?
So I'm going to jump on this one from the technical side of things. I can say yes, there are actually definitely different levels of validation. So as a case in point, we actually we brought on an LCMS system here in the past year. And as part of that validation, obviously, we're working on the test build and everything else. And a lot of those items can be covered in I believe it's the CAPS lab general checklist. But specifically, if you were to look up like the LCMS as a methodology, I believe it's in the Chem and Tox checklist, where they actually specify requirements for the data analysis software utilized by the instrument, that is distinctly separate from the LIS validation proper. So I would strongly encourage that whatever you are validating, if it's going to require the LIS piece, refer to your checklist, but also refer to your technical piece as well. So for instance, whatever that specific methodology is, just to make sure that there aren't additional requirements, that next level of items that you're going to want to look at and review as well.
I agree with Christopher.
I don't have much to add to that. Unfortunately, being in the lab kind of forces us to be a bit IT-ish. We have to kind of understand how the data flows and in order to do our jobs. So definitely important to understand how that data flow and every piece of software that's touching data before it hits the EMR.
All right. Well, I believe that is all the questions we have for today. Do you guys have any final comments you'd like to make? If not, that's okay.
Thank you for including me. And feel free to be in touch if anyone has a question. I'm happy to take any questions via email.
Yeah.
Same here.
Yes.
Yeah. Thank you.
Yes, we want to thank all of you for joining us today. Thank you to our panelists for a wonderful panel discussion. This was recorded and it'll be available on the ADLM website. So send it to a friend who might find it interesting as well. And again, if you have any other questions, feel free to reach out to us. We're more than happy to share the questions with the panelists or help you out where we can. So thank you all.
Thank you.
Bye.
Thank you again.